All right, so we will get launched then, and I'm glad you, Michael, mentioned we want to talk about how we get things done, what we can do about the problem, because I think our keynote speaker today, Dr. Elmer Huerta, is a great example of someone who has figured out how to get things done. So he is currently the director of the Cancer Preventorium at the Washington Cancer Institute at Medstar Washington Hospital Center here in DC. And he is really an innovator when it comes to cancer communication and health literacy. So early on in his career, he recognized that his patients knew more about their telenovelas and soap operas than their health. And so he realized that the way to reach the Hispanic community with cancer prevention and cancer information was through the media. And so he has been a leader in this regard. He has been the author of several best-selling books and also has been recognized by being appointed to the National Cancer Advisory Board by President Clinton and received many awards for his work in prevention. I'll refer you to his biography for all the details, but please join me in welcoming Dr. Elmer Huerta.
Thank you very much for the introduction. Good morning, everyone. I will talk to you in the next 20 minutes or so about the two sides of a coin in cancer prevention at the hospital where I work. As you can see, is the Washington Hospital Center, which is 10 minutes from here in the center of the city. And as Karen mentioned, I'm a medical oncologist by training. I did medical oncology in Peru, and I graduated in 1985. But after some years in practice, private practice, I just got disenchanted of the specialty because in Peru at that time, almost every patient I got died, in spite of all my efforts to give them chemotherapy and treatments, because the conditions that they had at that time were very advanced. So I realized that my place was not in medical oncology, and I decided to switch. That's why I came to the U.S. in 1989 to pursue a career in cancer prevention and control, which I completed at the National Cancer Institute at the Division of Cancer Prevention and Control. After finishing that training, is that I was hired by this hospital to start this program. At the same time, I was doing my studies, my residency, because I had to repeat all over again everything. I was doing radio programs to the community in Spanish here in Washington, D.C. And why the media? Because I remember very well the anecdote that changed my life. It was in 1986 in Peru. This woman was in the emergency room of the National Cancer Institute where I used to work. She was a young woman in her 40s. She was in this stretcher, pot of blood. She was bleeding through the vagina. And then I just went to see her as a medical oncologist, and I asked her, why are you in this state? Don't you know what a pap smear is? And the lady told me, pap smears aren't those things you do in your throat, Dr. Huerta, she told me. She didn't know the pap smear. She had this advanced cervical cancer. And I said, well, I started to examine her, and then I asked her, do you watch soap operas? And she said, yeah. And they say, have you watched Simplemente Maria, a very popular opera at that time? And she told me the whole plot of the soap opera. That's when I said, what's going on here? Why is that this woman is coming too late with such an advanced cancer? And she doesn't know what a pap smear is, but she knows by heart this soap opera. That's when I decided, and I said, maybe the media is communicating people just entertainment messages. Maybe there's a scarcity of health information to the public. So I asked myself two questions. I remember in 1986, the first question was, would it be possible one day to have a health facility with a sign at the door that would say, this is for people without symptoms only? If you want to talk about prevention and you want to have cancer screening tests, come in, this is for you. If you are already sick, the doctor next door can take care of you. Now, question number one. And the question number two was, would it be possible one day to sell health through the media, concepts, as we sell shoes or tobacco or alcohol using the media? So this is a little bit of that story. Let's see. We start with the reality of the healthcare system that we have all over the world. What is that? That is people doing what? Waiting for symptoms to appear. It is only when the symptom appears, somebody's bleeding or losing weight or having a lump, and they go to see the doctor, and they create this busy, illness-loaded primary care system that even use the emergency room to take care of. We know this all over the place. Why? Because the system is centered in the person with a condition, with a disease. What? This is the proportion of people living with the disease for whom the healthcare system has been designed. But this is people without any disease. Excuse me, maybe all of us. And look how the money goes. Only 3.1% of the money goes to this huge chunk, and 97% of the money goes to take care of patients. Why? Because our system is patient-centered. Well, how can we change this paradigm? How can we convince people to seek care when they have no symptoms? Would it be that possible? Would it be possible to have, for example, little clinics like a Jiffy Lubes all over the place where people can go, check up, and just have some tests, get out, see you next year if they are okay, like a car, in such a way that we can develop a health promotion, disease prevention-based system instead of a patient-centered system, which, of course, will develop a less illness-loaded primary care system. That's a thinking. Or, in other words, how to go from this, and I'm sorry about this picture, but this is what I used to see in Peru. This is breast cancer, advanced. How to go from this, which is advanced cancer, which happens here in the United States. I've just presented this PowerPoint to some group of oncologists a couple of weeks ago, and they told me, yes, we see that here in Washington, D.C. How to go from this, which is advanced disease that saturates the cancer health system with incurable and advanced cases, how do you go from this to this? There's a little calcification there. There is a mammogram, which is abnormal. You have carcinoma right there. You do just a lumpectomy, radiation therapy, and 99.9% of these women are alive and well 10, 15 years later. There's a polyp with some cancer in it. You remove the polyp, you do a partial colectomy, patient's cured. This is an abnormal pap smear. If it's a cancer inside of the cervix, you do a hysterectomy and you cure the patient. So how do we go from that advanced condition to early disease in such a way that we develop a cancer health system which is more focused on the care of early disease cases? Wouldn't it be nice to have that move, the whole thing? Well, in order for that thing to happen, we need to remember that the frequency of cancer in a certain locality, could be Washington, D.C., anywhere, not only depends on the biology of the tumor, but also on cancer control programs. You know this very well, laws. We need to work with this legislator, health policies, community health programs, and individual behavior. And the reason I underline biology of the tumor is because being a medical oncologist in my life, I've been very, very lucky. I went to many wonderful places in my career. And for example, the National Cancer Institute in Peru, only one cancer center for 30 million people. Then I came here, I spent 1 year at the Johns Hopkins Oncology Center, fine center. Then during my time at NCI, I had a rotation at the clinical center. Great places. But you know what? All these three places, when we were medical oncologists doing rounds and things like that, we only talk about the biology of the tumor. We had a patient right there. We were in front of them talking about markers, about responses to chemo. Patient didn't understand anything because we doctors were concentrated on the biology of the tumor. In other words, we shouldn't concentrate only on the study of the tumor. That's what I'm saying. If this is the cancer, We shouldn't only talk about oncogenes or the growth factors and the p53s or the apoptosis, the angiogenesis, and the enzymes, which are very important, yes. But you know what? We need to concentrate on the person with the tumor. Who is this woman who's coming with advanced condition? How much information does she have? Is she poor? When you are poor, your priorities completely change. I had patients whom I told them, listen, you have to do this, otherwise in 5 years you may regret it. And they said, Dr. Huerta, come on. I don't even know what I'm gonna eat next week. And you're talking to me about 5 years. They're poor. Fears, fatalism, lack of medical insurance, false beliefs, language. So all those issues are important as the enzymes and the oncogenes and the apoptosis. In other words, the knowledge, the attitudes, and the behaviors. So, said that, how can we convince people that 1 ounce of prevention is worth a pound of cure? That's also another question I had very early in my career. I'm convinced that coherent, consistent, media-based public education programs need to be created. And that's what I did. In 1989, as soon as I got to the United States, I created this ethnically sensitive, culturally relevant, media-based community outreach program on the radio here in Washington, D.C., following 4 basic principles. Number 1, use of the media consistently. What does it mean? Use it every single day, Monday through Saturday, like the weather, like sports. Do you conceive your 11 o'clock news without the sports guy? Impossible. Impossible. You will never find that. Sports need to be there every single day, like weather. Well, health, they should be there too. Number 2 is comprehensive, which means that it's not only cancer. It's tuberculosis, it's diabetes, it's maternal health, it's child health. It's a public education program in health, the whole thing. Number 3, we have to use all the media channels that are available for the community. So we have radio shows, 1-hour shows, we have 5-minute shows, we have Twitter, we have the Facebook, we have writing, we have the whole thing. Because people use all those channels, we have to direct our attention to all those channels. And number 4, this is very important. Over my 30-plus years of doing radio and television, of course, I've been approached many times by the sellers of vitamins and herbs and supplements, offering me a lot of money. I have always refused. So my messages are without any commercial support, and I have created trust. And that is extremely important when you communicate your messages. You need to be completely free of commercial interests. So some of the media tools that we have developed are, this is my radio show. This radio show, the Community Clinic of the Air, is now 26-year-old, 27 actually. And it's every day, 1 hour, every day from 1 p.m. to 2 p.m., I broadcast from my office at the hospital. I'm going to show you the studio in a little bit. But this is a great show. I talk to people, I take questions and communicate concepts in this 1 hour show. And then I do a lot of things with Peru, with my home country. I have 3 shows with them. I have my daily show, my daily radio show, a Saturday radio show, etc. And this is my studio at the hospital. You see? You see that's a little corner, that's a microphone, that's the digital machine, the mixer. That's where I broadcast. When I travel in the hotel, I set up the system, and then you can broadcast from the hotel. This is at home. And even at the airport, I was in Guatemala. I got stranded one day, and then you just set up your system, but you have now the technology that can help you to communicate. That's extremely important. And I am the medical correspondent for CNN in Espanol. I do for the Spanish channel what Dr. Gupta does for the English channel. And I have Twitter, of course. My account has 57,000 followers, very, very loyal followers that help me a lot with my media campaigns. And I write for the main newspaper in Peru. This is a weekly column on science and technology, and this is what they do. But that's the media. That's the message. Every day you communicate, you give messages and concepts. But you know what? After the public has been convinced to take preventive steps, they need a place to go. and that's the cancer preventorium that I started 25 years ago. The sanatorium, remember in public health, is the place for the treatment of chronic diseases or for medically supervised recuperation. That's the definition of the sanatorium, especially for patients who are convalescent. This is the first sanatorium in the United States, 1884, New York, Little Red, wintertime, you see all these people with tuberculosis. It was incurable, but they used to be at the sanatorium. This is how they used to live in the old sanatorium. Well, I went to look in the dictionary for preventorium, and it's not there. So we propose that preventorium is the institution for prevention and early detection of chronic diseases or for medically supervised patient education, a resort for maintenance of health, especially for people without evident illness. That is the preventorium. Michael Shimkin, probably many of you have heard about him. He was the ASCO founding member. He wrote in 1975 that people of the future will visit preventiries to receive health education, undergo cancer screening tests, and even engage in community activism. The preventorium has two main goals. Number one is to find and treat early asymptomatic conditions like cancer, diabetes, high blood pressure without symptoms, and to find and manage the risk factors for those conditions. That's the two main objectives of this clinic. We have seen up to the month of April of this year, 37,000 people, and 30% are male, 70% are female. That 30% of males is remarkable because at the beginning, for many years, I would say 10 years or so, my percentage was only 5%, 7%. Men, we don't like to see doctors. We don't like to go to preventative care. This is some characteristics of this group. Foreign-born Latinos, 94%, 95% male and female. The age range from 30 to 59. And the educational attainment, you see primary education, 1/3, just primary education, elementary school. High school, 30%. So 2/3 of these people, they have less than high school education. The country of origin reflects what we have here in the community, people from El Salvador, from Peru, from Bolivia. And the language preference, of course, they want to speak Spanish. And employment, they work menial jobs. The men, they just park cars, they do gardening. Women, they clean houses. They are really underserved people. They are immigrants. They came here over the last years. They don't speak the language pretty much. And of course, they have no health insurance. And this is the time of living in the United States. You see, 80% of males have no health insurance, 74% of females, they do not have health insurance. So we have a system set up. When we find something abnormal, we have a system where we can refer the patients in local community clinics so they can resolve their problem. And this is important. This slide is important because it shows that the reason for visiting the clinic. On the first column on the left, it says no symptoms. Those are people who come without any symptom at all. Say, hi, how are you doing? Any problem? No. Any pain? No. Anything? No. So where are you coming? Because I want to have a checkup. Good. Sit down. That's it. 30%. The third column is symptoms present, not believed to be cancer. So what do you have? Well, I have a little bit of headache here, but are you worried? No, that's my headache, my migraine, or I have back pains, things like that. That is 60% for males and 55% for females. If you add up these two columns, so 60 plus 34 is 94% of males, they go just to have a checkup, and a little bit less for women, which means that people, they just change their chip in their heads, and they are just going for preventative care. And now one word for this, because you know what? The hospital I work with, they peg the rate of the consultation to Medicare. So they pay $175 for this consultation. And they go wife and husband. So that's a lot of money for them. For these women, it's 3 houses they need to clean to pay that consultation. And for the men, it's 2 days of work. So how do you explain a person who is poor, who doesn't speak the language, who has no health insurance, who no formal education, and no money, they paying out of pocket to have this service. How did you hear about the clinic? It's radio, television, and now we are going to friend and family. So the program is now getting into the community. We follow this diffusion of innovation models as the basis of our work. Cases of cancer we found, very few, 89 cancers, early cancers. All of them, of course, have been referred for treatment. This is the model, community outreach through the media, which is the product I sell to people, saying, you know what, you need to see your doctor before you get sick. Otherwise, your American dream may be broken. The Preventorium is the store where people come to buy my product, and customer service is the navigation program that we have to make sure that every person, is taken care of. This program has been adopted by the National Cancer Institute in their summer curriculum in cancer prevention as one of the modules. So we give a lecture there, and people from many different countries who attend this conference, they go to visit and tour the Preventorium. So that's one side of the coin. The other side of the coin, so this is one side, convincing thousands of people who are poor and uninsured to pay an out-of-pocket fee for a preventative medical service. The other side of the coin is that we found that 99% of patients with advanced breast cancer seen at my hospital right here in Washington, D.C., do have health insurance, 99%. Look at this. In my hospital, you can see the third column, 22.7% of the cases of breast cancer in my hospital are stage 3, 4, advanced cancer. In national data is 10%. So we here at the national capital, 10 blocks from the capital, we have double the national rate of advanced breast cancer. People who, over 50% of them live in DC, they live around the hospital, wards 5, 7, and 8, which are the poorest in the city. 62% of patients come from these wards, and those are the wards in red. The dot is my hospital, where my hospital is located. And look at this. 99% of patients, they have health insurance. They have Medicaid, Medicare, private insurance, everything. So how is that possible? How is that possible that people who are American, they speak English, they have health insurance, they are middle class, living around the hospital, why are they coming late? So we did, there are 94% of them are African American living around the hospital. So we just started a program, inspired in Dr. John Snow's map, the cholera. So this is our map. Every pin represents a woman with advanced breast cancer. You can see all those clusters in Washington, D.C. In yellow is the location of my hospital. Every pin represents a woman living with breast cancer. So the same thing with colorectal cancer, exactly the same thing. So we have a program that's called Breast Cancer Prevention in the Neighborhood, phase 1, 2, and 3. And we found, we asked people, why do you think people are coming late? They say fear. They are afraid. So we need to fight fear in the community. And this is what we're doing now with phase 2, 3, and 4 of this program. This is a summary of the program we are doing at the Washington Hospital Center. With the media reach, community reach, political partnership. We work with the Office of the Mayors, the Primary Care Partnership, the Private Insurance Partnership, and the Government Insurance. So we have a coalition there to fight fear in the community. So we're finishing now. These two groups of people, the two sides of the coin. On the left, the Latino group that went to the Preventorium over the last years, and here the Ward 5 African Americans. They have some common characteristics like poverty, fear, fatalism, but they have different characteristics like, for example, culture are different, language, of course, immigration status is very different, and health insurance coverage. On the left, no insurance. On the right, 99% insured. Well, what is the difference? The main difference between these two groups is that this group, they had 28 years exposure to a daily media-based health education program, every single day for 28 years. whereas in the right side, there are no consistent educational programs. Dr. Michael DeBakey, he said that I still consider good information to be the best medicine, and that is very true. And Albert Einstein, he said that knowledge exists in two forms: lifeless, stored in books, and alive in the consciousness of men. And he said that the second form is the essential. Because what is worth to have all the information in books and shelves? That takes me to the last slide. What is that? That is the ivory tower of science. All of us are there. All of us. In this tower of science, there's a scientist having a brilliant idea. Doing what? Talking to another scientist, because we talk about each other all the time. And we have a very difficult language to understand. Our object of work is to write reports. We have reports on many things, and books, on papers, and guidelines. Extremely important work, because that's how science advances. Extremely important. But you know what? What sometimes we don't realize is that we are so concentrated in our work, in our ivory tower of science, that we don't realize that we are above the clouds. And we are completely isolated from these people. And that woman, she's going to go with stage 3, 4 cancer to the hospital, and there are guidelines to outreach them, written and papers and everything. Same thing, this man is going to come with advanced colorectal cancer, and we have guidelines and papers and books and reports on how to outreach and how to do early detection of colorectal cancer. But the message has not gotten to them. So our job is to translate all this information, all this enormous amount of information to people, but in terms that they can understand, in terms that they can take it and change the attitudes and the behaviors and have a healthier communities. That is our job. And this is what we were trying to do over the last years. Thank you very much.